committee chairpersons, the clinical research as well as quiz, along with Dr. Priya Kanappan. And at first, I would like to thank our President, Dr. Dana Lakshmi Madam, and our Secretary Malaraj and Treasurer Sumati, and our chief guest of the day, Dr. Jayashree Gajraj Madam, who is going to do a journal club moderate, as well as Madam is going to judge the debate. And these are our committee members: Dr. Bharati, Dr. Devi Sunaja, Dr. Nivedita Madanraj, Dr. Priyanka Sendilvelan, Dr. Ramai, Dr. Anandi, Dr. Janani, Satya, Swati, and Dr. Sukadara. So few of our members are today we are involved in the meeting. Next, I'm Deepa and Priya, and we start with our Oxy prayer. May I invite Dr. Priya Kanappan to do the Oxy prayer?
Thank you, Dr. Deepa, ma'am. So I would invite everybody to join me with the Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So can we have the CV of our MOC today? We don't have it. Yes.
Dr. Saranya.
Yeah, so Dr. Saranya, she is an assistant professor from ACS Medical College. So Deepa ma'am, can we hand over the session so that she can invite our speaker? Yes,
Yeah.
Saranya? Dr. Saranya, are you there?
I'm here, ma'am.
Yes, sir. Yeah, you can introduce madam.
It gives me immense pleasure to welcome Dr. Jayashree Gajraj ma'am. Madam is a senior consultant, Apollo Specialties Hospital, Mangai Women's Health Exclusive, MGM Healthcare. Madam is gold medal in clinical medicine in MBBS, President Oxy 2008, Chairperson AICC RCOG South Zone 2008 to 14, Founder Secretary and President Chennai Menopause Society, President AT NRCOG, President SOFC Tamil Nadu Chapter. She has received the Best Doctor Award from Dr. MGR Medical University, and Madam has many publications and chapters in textbooks in her name. We welcome you, ma'am.
Thank you. Thank you, sir.
Sahitya, have you received my PPT? My screen is not sharing.
Charanya, we'll go with the next one.
Debate?
Yeah, we'll go with the debate.
Then we come back to the journal club. Then Sakiti will be ready.
Yes, ma'am.
Okay, ma'am.
You introduce Anandi.
Ma'am, can I have her CV, please?
Yes.
Before we just move on to the two debaters,
Yes,
I thought a very short introduction of the topic itself and congratulate the team for bringing up this topic as a discussion point for their monthly meeting. We are all increasingly seeing more and more of PAS without doubt. And for somebody who has been around for quite some time like me, yes, this is something very, very new. There were days when placenta previa meant nothing to us. We would just post the case and we would know we could manage. We never ever thought that a placenta could be adherent except in the textbooks. But now we are seeing more and more of this thanks to many factors. And along with it, a search for, trying to see, are we the problem why this is happening? Or is it a tissue, inherent property of the tissue that is changing? Can we change our practices is probably the main take-home message which the organizers are planning to give today. So over to the two debaters. I wish you all the best. Over to Anandi and Sukada.
Sir, the CV slide, Sakiti.
So the debate is on placenta accreta spectrum stems from poor surgical technique or poor patient healing. We have Dr. Anandi and Dr. Sukada Rao. To begin with, I invite Dr. Anandi Venkatesan. Madam is MBBS, DGO, DNBOG, and MRCOG. Current designation, junior consultant at Sitapati Clinic and Hospital. She's received multiple awards. First prize in AICC RCOG paper and posters. Received the prestigious Dr. Jayashree Gajaraj Endowment Oration Award in December 2025. Authored chapters in Foxy Focus and Obsgyne textbooks. Her areas of interest are reproductive medicine, high-risk obstetrics, lifestyle medicine. We welcome you, ma'am. Dr. Sukada Rao, she's consultant OBGYN and director of Dr. U. Mohan Rao Memorial Hospital, Chennai visiting consultant in Apollo Cradle and Mehta Hospital. She's done her MBBS from Jawaharlal Nehru Medical College, Belgaum, and MD Obs and Gynae from Bangalore Medical College, Bangalore. She was the best outgoing student, multiple gold medals in medical school, and over 2 decades of clinical practice. We welcome you, ma'am.
Sharanya, do you want to just lay down the rules, ma? How many minutes for each, and what is the time for rebuttal?
Ma'am, we will keep 10 minutes for the first person, and we will keep it for the 12 minutes for the second one, and 2 minutes for rebuttal, madam.
Okay, fair enough. Are the two participants okay with that?
Anandi, is it like
Yes,
you want
ma'am.
more time?
Yes, ma'am.
Okay, then let's go ahead then.
Saranya, just have a watch on the time also, ma.
Yes, ma'am.
Is my screen visible, ma'am?
Yes, it's visible.
Yes,
Ma.
ma'am.
So, good evening, everyone. Thank you for giving me this opportunity. So, today I'm going to talk about this poor surgical technique which contributes to the placenta accreta spectrum. So, placenta accreta spectrum is not something which patients develop, it's a complication surgeons create. So, before we blame the placenta or the patient poor healing, we need to understand who damaged the endometrium and the myometrium. So, why this debate matters, first of all? Placenta accreta spectrum is one of the most obstetrician nightmare. It's a dangerous complication in modern obstetrics. The incidence is increasing due to rising cesarean section rates, and it is the leading cause of severe obstetric hemorrhage, major indication for peripartum hysterectomy, and is associated with massive transfusion requirements. It also contributes to significant maternal and neonatal morbidity and mortality. So, if we are very serious about preventing this PAS, we need to understand where it starts. So, I'm going to tell you it starts in the operating theater, and I'm going to take you through in the next 10 minutes. So, regarding the surgical technique, every incision into the uterus is going to create a scar. However, this is unavoidable. However, a bad scar is avoidable. So, the quality of the scar determines entirely by the surgical technique, and this is the greatest modifiable predictor of PAS. So, what happens when you give a bad scar to the patient? So there's myometrial deficiency because of inadequate uterine closure, there's niche formation, and there's impaired vascularization. Because of that, there's deep invasion as a compensatory mechanism, and the cumulative risk amplification, which means that the incidence of placenta accreta spectrum disorder increases with rising cesarean section rate. So what is the anatomy of the poorly performed cesarean section? So what are the 6 technical failures which happens and creates a bad scar? The first one is the incision placed too low, which is in the cervico-isthmic junction, which results in a niche or isthmocele. The second one is a single layer uterine closure, which creates a myometrial thinning. A third is a locking suture with excessive tension, which creates a decidual deficiency. The fourth is inclusion of deciduo or the endometrium, which creates a permanent endometrial defect. The fifth one is the peritoneum left open or poorly sutured. Therefore, the bladder gets adherent to the lower uterine segment and it can lead to placenta percreta. The last one is the hemostasis driven over suturing, taking blind sutures in the to arrest the bleeding. So this can create large niche or dehiscence. So let's see what is this isthmocele or niche. So if you look at the cesarean scars, 24 to 70% of post-cesarean scars show niche or isthmocele on a transvaginal ultrasound. So if you see this figure, the niche is nothing but a defect in the scar in the anterior uterine wall. So when it is significant, the depth of niche is more than 2.5 mm and the residual myometrial thickness is less than 2.5 mm. It's clinically significant. So why this niche happens? This is important because then only we can prevent the placenta accreta spectrum. So the niche happens because of poor closure technique, taking a single layer, locked or ischemic healing, the myometrial defect forms, there is residual deficiency, there's abnormal implantation and PAS develops. So what does the evidence say? If you look at a women who have had vaginal birth, no previous surgeries, the median myometrial thickness is about 11.6 mm. But if you look at a women who have had a cesarean group, the measurements keep decreasing with increase in the cesarean section rates, and this is statistically significant. In addition, if you look at the scar defects, in a vast majority of patients with increased cesarean, the scar defect is increasing. And if you look at it's 100% for a women who have had 3 or more cesareans. And interestingly, in one study, they have looked at distance between the deficient scar and the internal os. And they have found that it's 0 millimeter, which means that the incision is placed so low at the cervico-isthmic junction. So now let's come to the single layer closure. So what happens when you do a single layer closure? And this is the most shortcut which everybody practice. The single layer closure results in a thinner residual myometrium and it forms a niche formation resulting in PAS. So what does the evidence say? The evidence does not recommend single layer or double layer closure for preventing PAS. However, if you look into deeply, the evidence says that if you do a single layer closure, it results in a thinner residual myometrium and that results in a large niche and that can affect the scar quality and that increase the placenta accreta spectrum. So this is a hot of the press article, NICER study. It's a trial which is performed in 2025 and they have compared the single versus double layer closure. And they have told the double layer closure produces fewer scar niches and thicker residual myometrium, basically a better sonographic scar appearance. So next we come to the locking suture. When you lock the first layer, it reduces the perfusion, thin the myometrium and give you a bad scar. So why does locking suture thins the myometrium? It's because of the ischemia malapposition hypothesis, basically ischemic necrosis of the myometrial edges. So this is a study which compares the single versus double layer suture in AGOG. This is again a study in Journal of Obstetrics and Gynecology of India and BJOG. All the 3 articles, they have said that the lock first layer closure was associated with lower residual myometrial thickness. And this is again a hot of the press article, this published in January 2026 in AJOG. They have told about specific steps for uterine closure after cesarean delivery. And they have said from a physiological standpoint, locking may concentrate stress and increases the compromise the microvascular perfusion. Non-locking sutures, however, will distribute the tension more evenly, therefore reducing the focal ischemia. Therefore, unlocked continuous suture should be generally preferred. And they've also said that the first layer should exclude the endometrium. So what is that? What is exclusion of endometrium? So if you include the endometrium, basically you're taking a full thickness suture, including the endometrium and the myometrium. The endometrium gets trapped between the myometrial edges and that leads to niche formation and abnormal implantation and PAS pathway. So this is one of the most cited reviews, Sholapurkar in 2018. He has said that when you include the decidua and the endometrium, it basically gives you a weaker scar, a scar defect formation and niche development. So the key concept is that the myometrium should oppose the myometrium rather than myometrium getting contact with the decidua. So what does the evidence say now? So the NICE or the ACOG, they do not recommend exclusion of evidence for preventing PAS. However, again, if you look deep into the article, the cesarean scar defects frequently demonstrate entrapped endometrial tissue and the myometrial to myometrial healing is not proper and there is a large niche formation which is an anatomical substrate for abnormal placentation. Therefore, there is an indirect link between the inclusion of the endometrium and the abnormal placentation. This is again the article which is published in January 2026 and they have mentioned that the second layer will improve the residual myometrial thickness. However, the critical factor for optimal healing is exclusion of the endometrium. Myometrial approximation is achieved and the endometrial inclusion should be avoided. So let's put all this together. So for a normal uterine healing, there should be a double layer closure, excluding the endometrium, just opposing the myometrium to myometrium, non-lock suture. Therefore, the endometrial basal layer is preserved. In the next pregnancy, there is a functional decidua basalis. So it limits the placenta from invading the superficial anchoring villi and the placenta gets separated normally. But what happens when you give a bad scar to the patient in a single layer or an ischemic closure, or if you include the endometrium, the decidua basalis gets absent. There's just scar and the fibrinous deposition. So there's no decidua to limit the placenta. Therefore, the placenta gets invaded as an accreta, increta, or pecreta, depending upon the weakening of the scar and the fibrosis. So this gives you a PAS consequence. So if poor surgical technique creates a placenta accreta, then optimized surgical technique is the only modifiable risk factor we can do for PAS pathogenesis. So standardize the double layer non-locking closure and optimize the incision placement, not too low in the cervicoisthmic junction. It should be high enough in the lower uterine segment. And judicious hemostasis should be achieved, not taking blind mattress sutures for the bleeding points. Obviously, reducing the cesarean rate, the WHO target of 10 to 15% is again a PAS prevention strategy. Surgeon training and supervision is very, very important because in a trainee cesarean, there's 3 times scar defect rate. And post-cesarean scar surveillance is 6 to 12 weeks post-cesarean. So I would like to conclude by saying the knife that cuts the uterus today plants the seed for placenta accreta tomorrow. The quality of the scar is under the surgeon control. Thank you so much, ma'am.
Thank you very much, Anandi. That was an excellent walkthrough of the techniques and the build up towards what can go wrong if we don't do things right. You had adequate references also. Thank you very much. We now move over to the other side of the argument by Dr. Sukada Rao, who obviously believes that we all are very good surgeons and we do the right thing when we do our surgery. So over to Sukada to defend all of us.
1 second. 1 second, ma'am. I will. All right. Thank you. Thank you, organizer, for giving me this opportunity. I'm here to defend us. Yes, I'm here to defend us. I'm here to demonstrate it's not the surgical technique, but the intrinsic tissue biology that is the primary driver for placenta previa spectrum. We stand in the dock today accused of causing the most devastating complication, that is PAS. Is it our hands, our decision, our scars that led to this catastrophe, or we have simply inherited a problem that was never ours to own? Are we truly guilty? Guilt without evidence is not accountability, it is self-punishment. Before accepting the verdict, let us deep dive into the science. Is it our technique that is failing, or it is the patient's own tissue, her biology, her healing response that is at fault? For if we could fix this, we can spare the woman from this dreaded complication. What causes PAS? Is the placenta that is aggressor, or is it the scarred uterus? If defective scars were the dominant cause, PAS should have never occurred in unscarred uterus, isn't it? But we do have a lot of cases reported. So at the cellular level, in the maternal-fetal interface, there is aberrant epithelial mesenchymal transition and aberrant maternal-fetal inflammation, dysregulated angiogenesis, abnormal signaling at the deciduo-endothelial interface. And also, the uterine natural killer cell, which is the invasion regulator, there is a dysfunction of that. Uterine natural killer cells regulate trophoblastic invasion depth, and in PAS, there is quantitative and the functional UNK deficiency. These are genetically determined and hormonally regulated. They are entirely patient intrinsic. No surgical technique can compensate for their absence. However, there is no denial that with the increasing rate of cesarean, there is an increasing incidence of PAS as well. So basically, it is a defective deciduralization and defective scar that has combined caused this problem. Now, what causes this defective scar? Is it the faulty technique? No, it is not. It is a patient's biology. It's not just our blade. Two women, same surgeon, same technique. One develops PAS while the other doesn't. So the variable is not us, it is her tissue. Even with regards to uterine niche, which is an ultrasound testimonial of a defective scar, there was a study done, and in that study, they found that the same surgeons following the standardized CS technique, even with them, there was significant inter-individual variation in both isthmocele size and scar depth. So niche is not is a healing failure. It's not a technical one. Stegway showed that the niche formation in CS correlates with patient's BMI, uterine position, and hormonal environment. All of this are outside surgical control. A niche represents failure of myometrial regeneration, faulty stem cell recruitment, fibroblast activity, or faulty angiogenesis, and remodeling. All these are patient intrinsic. The surgeon closes the uterus and the patient's biology determines what happens next. Decidualization, of course, is the reason why this whole PAS is happening. Deficient basalis and not myometrial disruption is the initiating event. The decidua normally acts as a biological brake on trophoblast invasion. When the brake fails, invasion is unchecked. The question is, why did the decidua fail? One of the reasons is endometrial stem cell dysfunction. These cells are responsible for regeneration of functional endometrium. Dysfunctional cells can result in fibrotic and hypovascular scars. And women with PAS have shown to have this kind of dysregulation. This is an intrinsic cellular failure that the surgeon inherits but not create. A core study done in 2026, this is the latest. They have used human surgical specimens, 3D imaging, mouse model, and Accreta in dish co-culture system. What was the finding? There are disorganized, tangled, excessive fibrillar collagen plus persistent macrophage-driven inflammation in the scars that led to PAS. PAS is a result of a faulty scar modeling and not because of bad surgery. We are here to fix the problem, not to fix the blame. So let me look again into the surgical technique of the uterine closure and see if we are at fault. There are three phases of scar healing. One is inflammatory, the second one is reparative, and the third one is remodeling. Remodeling can take 3 to 4 weeks to 1 year. Here, it has been noted that if shorter interval of interpregnancy interval, there is an increased incidence of PAS, and this we can take it as a learning curve and tell the patients to avoid pregnancies, frequent pregnancies. Regarding the uterine closure, single layer or double layer, Caesar trial and Coronis trial said there was no difference in the short-term or long-term maternal outcome. Nice's trial said double layer closure produced fewer severe scar niches and thicker residual myometrium. But with regards to PAS, there was no difference. Two close study, which was a multi-center RCT, also found no difference in the niche or other symptoms. Adding a second layer can improve residual myometrial thickness, but doesn't alter the risk of PAS. What about continuous versus interrupted stitches? Suzy et al., they said severe defects were seen only with 2% with interrupted versus 22% with continuous. And Sumikma said that the risk of PAS is more with continuous. But both these studies were limited by design. In routine practice, however, continuous suture remains far more common as it is faster, simpler, and uses less suture material. What about locked versus unlocked? Locking prevents slippage and allows tighter tension control along the suture line. But there is a possibility of compromised microvascular perfusion. Studies show that residual myometrial thickness and risk of subsequent uterine rupture may be different. So, but PAS, no. Available data say locking itself is not independently harmful and does not have any impact on the risk of PAS. Regarding suture materials, barbed materials and non-absorbable sutures, they increase inflammation and they can potentially interfere with the healing, but we do not use them in routine practice. Parallel versus perpendicular. Parallel has a potential benefit of reduced stress and focal ischemia, but doesn't alter the risk of PAS. Per string, meta-analysis shows lower scar defect, but there is a risk of circumferential ischemia and tissue strangulation. This study, this is the latest one conducted by Patricia and Bargela in 2026, and they have studied specifically the uterine closure techniques during cesarean and the risk of PAS. The conclusion of the study was, as of now, it is impossible to mandate a specific uterine closure technique during cesarean with the aim to reduce the incidence of PAS. Also, our other person said, with the increasing number of cesarean, the risk of PAS is also increasing, regardless of who operated. To summarize, it is the disrupted maternal fetal interface due to scarring or extracellular matrix modeling, dysregulated signaling pathways, immune vascular alteration, and these all collectively predispose for morbid placentation. We must therefore shift from guilt to biology and focus on prevention. Once we stopped asking, what did I do wrong? And started asking, does this tissue heal? A 60-year-old animal study became the foundation for the recent breakthrough. And that is endometrium-free closure. Podevin in 1961 conducted experiments on pregnant cats and rabbits comparing the closure techniques in opposite uterine horns. He found all inclusion closure resulted in impaired uterine healing compared to 0% when the endometrium was excluded. So when the endometrium-free closure technique was applied in a 2019 cohort study, there was 0 cases of PAS in 727 subsequent pregnancies. So endometrium-free closure technique optimizes healing and dramatically lowers the risk. So we should now aim at biological repair, not just mechanical closure. For that, put the incisions at the right place, as told earlier, avoid low incision, practice endometrium-free closure technique, and also consider intraoperative injections of PRP or mesenchymal stem cells into the myometrium. Although more research is needed before this becomes a standard procedure. So are we guilty? No, not for PAS. Evidence doesn't support that verdict. But are we done? No, because replacing guilt with curiosity gave us the endometrium-free closure technique and research into this regenerative adjuncts. One day, with everything this modern science has to offer, we can be sure that of no PAS in subsequent pregnancy. Thank you.
Excellent, Sukada. I think a big hand for both the debaters. You've done very, very well, collected ample references and put forth your arguments very beautifully. It's time now for a 2-minute rebuttal for Anandi before we start taking the call. Anandi?
Yes, ma'am.
Yeah, go ahead.
So, yes, Dr. Sukatia ma'am mentioned that healing matters. Yes, I do agree that healing matters. But healing can only occur on the foundation that we leave behind. Healing doesn't occur spontaneously. A scar is not a spontaneous event of nature, and it is a surgical outcome. And if you look at the placenta accreta spectrum disorder, it's fundamentally an iatrogenic disease, which is mentioned in all guidelines. And the strongest epidemiological risk factor so far mentioned is a previous cesarean section. So if you look into the guideline, the most common is a previous cesarean delivery. Nowhere they have mentioned poor patient healing or any other risk factors. And if you look at, as ma'am said, the risk of placenta accreta increases with the risk of cesarean section. If poor patient healing contributes it, why the risk of increase in cesarean also increases the risk of placenta accreta? It's almost like 67% incidence when you have 5 or more cesarean delivery. Yes, some women heal badly, absolutely. But poor healing cannot explain why PAS risk tracks so closely with the number of cesarean deliveries. The variable changes here is only the repeated surgical disruption and giving a bad scar. So if you look into this article, the niche defect theory, the entire field now accepts that the surgical technique influences the cesarean scar niche, isthmocele, and the residual myometrial thickness. But they have said that indirectly it affects abnormal placentation. They have not told that these surgical techniques prevent PAS, but however, they have said that these surgical techniques create isthmocele and it also affects abnormal placentation. So if you look at this paper, which is written by the Eric Jeinix, and he wrote about new insights in the etiopathology of placenta accreta. And he has mentioned that the scar and the placenta are part of the same story. Placenta accreta spectrum does not occur in a pristine myometrium. It occurs where the normal decidua has been replaced by the scar. So if you look at the patients who have developed placenta accreta, 100% they would have had a previous surgery only, or at least a DNC, where the decidua basalis has been compromised. So the pathogenesis of placenta accreta is myometrial disruption, defective decidualization, trophoblast invasion, and who creates that myometrial disruption is the surgeon. Healing only comes afterward. So, failure to prove a mechanism by evidence is not a proof that the mechanism does not exist. If you want to wait and watch all the smokers who develop lung cancer and then advise them not to smoke, similarly, when you look at all surgical steps and wait and watch to become a placenta accreta, and then you say you don't perform the surgical step. So, we may not yet know which surgical step matters most, but it is again premature to conclude that none of them matter. So, I'm here to conclude that I'm not arguing that healing is unimportant. Healing undoubtedly modifies the risk. But placenta accreta spectrum begins with the disruption of the uterine wall. The patient heals the scar she's given. If you give a bad scar, then there is a poor healing. The surgeon creates the scar that must heal. Therefore, if you are discussing the origin of placenta accreta spectrum, surgical technique deserves to remain in the dock before patient biology is called to the witness stand. Thank you so much, ma'am.
Thank you very much, Anandi. Deepa, do you want to take a call from the audience, or is it something? I think my sum up of this is, first and foremost, as I said, excellent presentations by both the debaters, beautiful arguments for and against, and you've put in a lot of hard work over a topic which is fairly recent, and you've done an excellent job. So without doubt, I think there is both factors are important for any scar to form. To begin with, inherent tissue pathology or tissue characteristics are extremely important, and we all know a scar over a bone is different from a scar over a soft tissue, scar over a bowel. It varies, as fundamental as that one tissue to another. There is a lot of change. But in every scar, the technique is also extremely important. So a good combination of selection is what I would probably recommend. And maybe in one sentence, if we were to say we want to prevent PAS, what do you think the answer to that is, Sukada or Anandi?
Yes, obviously it will be to reduce the number of cesareans.
Exactly.
And I assume and presume that all of us are here who are doing the surgery, taking the due care, and not doing unnecessary tension. I mean, locking stitches, which are too much of a tension, as if to create an ischemia there. The basic steps most of us have to follow. There is no doubt about it. You can't do an useless surgery. But all the studies are saying it is the decidua which is at fault. It is the endometrium that is at fault, which I told you the advance in the technique will help us.
So I think the main thing, the recommendation that we follow guidelines is very important. And as far as cesarean section is concerned, the NICE guidelines are excellent. I myself have seen over the years the 2 layers slowly becoming a single layer, and then things going back to trying to go back to the 2 layer. People still doing locking sutures, and I think it's important for us to sit up and think about our techniques. It's extremely important, and you have clear guidelines to follow. So let's combine both, and I think we will definitely have a good outcome. Our aim is certainly to reduce PAS without doubt. So my vote goes to both of you.
I have one thing. My vote goes to Sukata because there are Arabian ladies who are having 9th or 10th C-sections. Okay. Still, they don't have placenta. We have not seen much of placenta accreta in those ladies, madam. So I felt like there is the fault is really with the patient.
So maybe you have good surgeons in the Middle East.
No, but those days, leave it off. Those days in our periods, like before that, when you people are there are so many cesarean sections has been done, madam, in a government practice or outside. But the incidence of placenta accreta is not like this.
Never. As I told you, it was only something for the textbook.
Textbook, it's nutrition, so all lots of other factors, poor healing, nutrition, all factors rather than to blame the surgeons, madam. Sorry, Anandi. Technically, you are correct.
I don't think either of them blamed the technique or the tissue.
Okay.
It's ideal to take arguments from both sides.
Yes.
A good combination of the two will
Yes.
give you a very good outcome. So my vote goes to both of you.
Thank you.
Thank you, ma'am.
So, Saranya, your presentation is ready?
Yes, ma'am, I am sharing it.
Yeah. So we all know next is a journal club. Dr. Saranya is presenting about this article. And over to you, Saranya. Saranya is from the assistant professor in ACS Medical College. She is almost attended most of our quizzes and in everywhere, wherever Dr. PK is going, and she got almost all prizes. She did her MBBS from Theni Medical College and MSOG from PSG Coimbatore. And she did her fellowship in minimally invasive surgeries, and she also had Oxy, CMS and FEPA memberships, and had Best Paper Award in International Labour Congress, and also winner of Boxy Usha Krishna Quiz South Zone Visak and IAC OG Indu 2021. Over to you, Sharanya.
Thank you, ma'am. Thank you for the kind introduction.
Share.
Is my screen visible?
Not yet, ma.
Sahiti, can you share my PPT? No, what is happening?
Ma'am, just give me a second, ma'am.
Yeah.
If Anandi or Sukada are able to share it, maybe we can just send it to them.
Saranya,
I sent it to them, ma'am. I sent it to them.
You can send it to me. I'll share it.
That's what, because we've just known,
Saranya, you can even send it to me. I am here.
Yes, ma'am. I'll send it to you, ma'am, right away.
WhatsApp.
Yes, ma'am. I've sent it.
I received it. 1 second. I'm sharing.
Yes, ma'am.
Able to see the screen?
Yes, ma'am. Yes, ma'am.
Yeah, very good.
Can I start, ma'am?
Please.
So the journal is on simple conservative surgery for placenta accreta spectrum without parametrial invasion. That is called SCAPAS, a novel uterus sparing approach. It was published in the American Journal of Obstetrics and Gynecology Global Reports in Volume 6 of February 2026. The author is A.N.H. Dui Nguyen et al. The place of study was the Department of High Risk Pregnancy, National Hospital of Obstetrics and Gynecology, Hanoi, Vietnam. It was a prospective observational study. So the background, placenta accreta spectrum is a life-threatening condition often managed by cesarean hysterectomy, resulting in numerous negative impacts on women's health. Most PAS cases do not involve parametrial invasion and may not require aggressive or complex surgical approaches. However, no simplified uterus sparing technique exists for this subgroup. Therefore, a novel surgical approach, SCAPAS, tailored for PAS without parametrial invasion, was developed. So why this study? Most PAS cases do not involve parametrial invasion. However, current surgical approaches are often designed for all the PAS types. These complex techniques requires advanced procedures and may not be suitable for low resource settings. This study introduces and evaluates the safety and effectiveness of a novel, simple, conservative surgical approach for PAS, tailored for PAS without parametrial invasion, as most cases do not involve parametrium, needed for a simpler fertility preserving approach suitable for low research setting. So the objective was to evaluate the efficacy and safety of SCAPAs in conservative surgical management with PAS without parametrial invasion. It was a prospective study in Hanoi Obstetrics and Gynecology Hospital, Vietnam, conducted from January 2022 to June 2023, and it included 63 women. So the inclusion criteria was an established case of placenta accreta spectrum, women who underwent elective cesarean section more than 35 weeks and no parametrial invasion. Exclusion criteria was emergency C-section done due to severe vaginal bleeding or fetal distress, PAS 3, and no PAS on postoperative pathology. A few words on the classification of this is the PAS classification, prenatal ultrasound staging system. So PAS 0 is placenta previa with no ultrasound sites of invasion. And PAS 1 is our area of study, presence of at least 2 ultrasound signs, that is placental lacunae, loss of clear zone, or bladder wall interruption. So that will include a placenta accreta and increta. So according to figure, it will come under type 3. PAS 2 is PAS 1 plus utrovesical hypervascularity. So placenta percreta, focal or diffuse. PAS 3 is PAS 1 or PAS 2 plus evidence of increased vascularity in lower uterine segment. That will include placenta percreta. So our exclusion criteria says PAS 3, it includes only PAS 1 and PAS 2. So a woman with placenta accreta spectrum was admitted for C-section more than 35 weeks. So these number of cases were excluded. Who underwent emergency C-sections were 11. Suspected signs of PAS 3 were 7, and there one refused participant. So from 84 women, 65 women were taken. And on post-operative pathology, there was no PAS in 2 cases. So the final study was 63 people, out of which 54 of them underwent this uterine conservative surgery and 9 of them proceeded to hysterectomy for other reasons. So what are the steps of SCAPAs? The first step is bladder flap and vascular disconnection of new formed vessels between lower uterine and posterior bladder. Then we have to make a transverse incision of the high uterine lower segment at the upper border of the neovascularity. Deliver the fetus, followed by immediate combined uterotonics. Temporary hemostasis on the edges of the uterine incision. Exteriorization of the uterus out of the abdominal cavity, followed by bilateral uterine artery ligation. Then active placental extraction and resection of all the invaded myometrial tissue, applying local hemostatic sutures in the uterine walls to control residual bleeding from the placental bed. Then we have to identify the internal os and lower uterine segment and repair the uterine incision. So this image shows taking the bladder flap and giving the high, B shows giving the high uterine incision. Then after delivery of the fetus, bilateral uterine artery ligation, and we have to extract the placenta and identify the internal os and repair the uterus. So the baseline characteristics of the 63 participants were analyzed. Maternal age, so less than 35, it included 74.6%. Number of deliveries were 2. Number of previous C-sections, those who had more than 2 C-sections had 52.4%, and gestational age did not give much significant value. And position of placenta, anterior partial placenta previa, had 55.6% of incidence. And PAS 1 was 30.2% in the cases, and PAS 2 was 69.8%. That is 44 participants were PAS 2. Next. So the primary outcome was the uterine preservation rate was 85.7%. That is 54 cases out of the 63 cases underwent successful uterine preservation surgeries. Then others required subtotal hysterectomy for various reasons. Out of which PASS 1, the success rate was 100%. All the cases of PASS 1 underwent successful uterine preservation surgery, and PASS 2 was 79.5%, in which Accreta was 82.4% and Accreta was 27%. The secondary outcome studied where the median blood loss was 1200 ml, which when compared to many other studies was much less. Blood transfusion rate was 66.7%. The median surgery duration time was 80 minutes, and the hospital stay was roughly around 5 days. The fetal outcomes included median birth weight was 2.7 kgs. Apgar less than 7 was only 20.6%. At 5 minutes, it was absolutely 0%. And NICU admission was only 1.6%. That's only one baby was admitted. So the intraoperative complications included bladder injury was 6.3%, postoperative wound infection was 4.8%, and there was no case reported as relaparotomy. So comparing with the other approaches, than one-step approach, it had 80% more success rate. With stepwise approach, it had 91%, and with Moscus, it had 93%. Strength of the study. It is a prospective design, standardized 8-step protocol, reproducible technique. It can be used in low resource settings, high uterine preservation rate, and avoids complex steps like internal iliac artery ligation or preoperative interventions. Balloon occlusion or JJ stent placement.
Dr. Sheila, please mute yourself. Dr. Sheila Ramakrishnan.
Saitya, can you just mute everybody else except the speaker, ma?
Yes, sir.
Can we move to the next slide, ma'am? The limitations of the study was it was a small sample size and it was a single center study. There was no other control group included, and the PASS 3 was excluded. So we do not know how the outcome for PASS 3 will be with this type of conservative surgery. And there was no long-term fertility outcome was studied. Shall I play the video? It is of 8 minutes. Can the video be played?
Yeah, I think it will benefit everybody. So if the organizers are okay, we can play it.
It's okay, ma'am.
Go ahead.
Ma'am, can you play it, ma'am?
I should. Okay, sorry.
Abdominal cavity via previous scars at midline. Step 1. Bladder flap and vascular disconnection of new formed vessels between lower uterine segment and posterior bladder to isolate the bladder from the uterine segment.
All the vessels are being cauterized after raising the bladder flap.
Step 2. Transverse high uterine incision at the upper border of the placenta, which is realized by the area of new vessels without cutting through the placenta to avoid severe bleeding. Step 3. Fetal delivery followed by immediate administering of combined uterotonics, including oxytocin, agometrine, carbetocin, etc. Step 4. Temporary hemostasis on the edges of uterine incision by pince-en-cœur. Step 5. Exteriorization uterus out of the abdominal cavity, followed by bilateral uterine artery ligation.
சரி நான் கேட்டு சொல்லிடுறேன்.
Yes, Sharanya, go ahead.
So to conclude, SCAPAS is a simple, safe, and effective surgical approach for conservatively managing placenta accreta spectrum without suspected parametrial invasion. However, further studies are needed to develop a preoperative classification based on location, extent, and degree of invasion to improve outcome in all types of PAS patients.
Good. Thank you very much, Sharanya, for a
Thank you,
beautiful analysis of the presentation.
Thank
I
you.
have a few questions to ask, and let's see how we take it forward. One was that I think my initial thing was number of previous cesareans, and you had presented that in your
Yes, ma'am.
thing. What about the anesthesia used? Was there any mention of whether it was a general anesthesia or a regional?
No, ma'am. In the article, there was no mention, ma'am.
Or do you think that could make a difference?
Not much, ma'am. The median time said it was only 80 minutes, ma'am, in this study.
80 minutes from beginning to end.
Beginning to end, yes,
So
ma'am.
which brings me to my next question. Incision to delivery time, did it make any difference? Was there a difference? Was
No,
that
ma'am. It was not mentioned in the journal.
okay? So again, do you think there could be a delay because of all the initial things that we are doing?
Yes, ma'am. Yes, ma'am. There might be a delay because if the vascularization is more, it will take more time to cauterize each specific vessels and then get
So
into.
therefore, what kind of anesthesia would also influence? And somebody had asked in the chat box what incision was used. So what incision was it mentioned, and what do you think would be the ideal incision? The abdominal wall incision.
Abdominal wall incision was not mentioned, ma'am, but from the video, I think it was suprapubic incision.
Okay, so you think that's a good idea, or you think we should go for a midline vertical?
As from where I have assisted, we usually go through suprapubic only, ma'am.
Okay,
We
for a
do
pass.
for a pass, yes.
What technique are you used to using for a pass?
Mostly we try to take the placenta as much as possible, and then wherever it is attached, we try to excise along with a bit of a myometrium, and then we apply hemostatic sutures, ma'am. I have not assisted where the myometrium is excised in a large scale, but I watched the surgeries being performed in conferences, ma'am.
Okay, so you are routinely actually taking out a part of the myometrium. Is it a window of the
Yes, ma'am.
myometrium?
Where it is attached focally, and in one case, we even kept a suction cannula inside for a few hours for the bleeding to get controlled. And we observed for in about 4 hours, the bleeding completely stopped. And we kept suction cannula on and off for a period of 4 hours.
Okay, and did the blood loss vary according to the number of cesareans that were there, the previous cesareans, or was there any difference?
It didn't make much difference, ma'am. We had the blood ready, and as soon as we started the incision, we expected much
We are
blood
coming
loss.
back to our paper.
Yes. Oh.
Yeah.
Ma'am, in the paper, it was the median blood loss was 1,200 ml, ma'am. It was compared to other studies.
They have not.
It did not cause much, ma'am. It was estimated around up to even the median was from 850 to 3,200, which averaged around 2,000 to 2,500 ml, ma'am. But here it was only 1,200 ml.
So, any presence of comorbids, obesity, GDM?
It was not
Hypertension.
studied, ma'am. Those aspects were not studied. Yes, ma'am.
Okay. And finally, do you think it would have been a good idea? I mean, the method sounds like a great idea, but if we were to combine it with what most of us are used to, for example, bilateral balloon placement, if the same thing is combined, do you think we will get a better? I agree with you, hysterectomy is not the answer, but maybe we should be combining balloon placement along with this technique. Do you think that would make a difference?
Yes, ma'am, it will. But the study was mainly focused on pass 1 and 2 without any invasion, ma'am. So maybe for that, for PAS3, like how I mentioned, for that balloon occlusion will be more helpful. And for this, that is the reason why they did this study, ma'am, to prevent all that. And it gave a very good success rate compared to the other techniques. So maybe to avoid that, this can be tried.
And only ultrasound was used to evaluate PAS 1, 2, or
Yes,
3.
ma'am, only ultrasound was used.
No MRI was
There
not.
was no mention whether MRI was used or not.
So, and the last thing is that to say that this is good in a low resource setting, are you sure that's the right statement to make?
No, ma'am. As an obstetrician, when we see a basic placenta previa itself, we definitely go for a MRI at around 32 weeks, ma'am. So with no with all the advanced techniques only, it is safe to proceed. I don't know how much I will be using this, ma'am, but
on balance, how do you want to sum up your view of this paper?
Maybe, ma'am, when it is a minimal pass 1 or a simple placenta previa pass 1, we can try this, ma'am. We can try this provided we have a backup of the other methods also available in hand with a good experienced person also with us every time.
Thank you, Sharanya. I think a very good run through of the paper. But as is obvious, there are a lot of flaws in the reporting itself.
Yes.
And I think we need to probably, not just take it, but take it with a pinch of salt, because I don't agree with most of what they have said. But the same topic with a more thorough evaluation, I think there is a definite room for evaluation there. So thank you very much.
Thank you, ma'am. Thank you. We can move on to the quiz, ma'am.
Yes.
Yeah, I'm fine. Deepa and Priya.
Ma'am.
You can, Charani, you can introduce Janani.
So next we move on to the interesting part of today's session, the quiz, which will be moderated by Dr. Priya ma'am and Dr. Janani Venkat. Dr. Janani Venkat has completed her MBBS from Tanjavur Medical College, MSOG from Madras Medical College. She's a junior consultant at Sitapati Clinic and Hospital. She's presented multiple posters, papers and capsules. She's a member of OXY. We welcome you, ma'am.
Janani, are you there?
Ma'am, for the introduction. Yes, ma'am.
Okay. So, no, thank you. I think we'll go with this. Thank you for the introduction for me. So, for people who know me, and if you don't know me, I'm Dr. Priya Kanappan. I'm one of the quiz committee, South Zone coordinator for the Foxy Quiz Committee. So, and, very interested to do the quiz. So, we will go with the Kahoot quiz for this time. I hope my screen is visible. So, I will go with the Kahoot. Sorry, I could not add more questions, so I was held up. So for people who already know, we know that once you go into this platform, you have this QR code. You can just select that. It will take you to the Kahoot app. Or you can go and enter www.kahoot.it. Or if you have a Kahoot app, go into the Kahoot app and then you can enter the game pin. So the game pin for this will be 9741036. Yes, thank you. So you can join with your full name, so it will be easy for us to address you. So kindly stay. We have almost 50 participants in our group. We will wait till most of you are joined and then I will start the quiz, because in Kahoot, once you start the quiz, we will not be able to add more participants. So we have 10. At least once we have a number of 30 or 35, I think Janani can start with the quiz programs.
Yes, ma'am.
Priya, I thought part of the fun in Kahoot was having
So
nicknames.
we have almost 30.
Not your
I
real
request all
names.
of you to join as early as you can. So today's question for the quiz will be on APH, antepartum hemorrhage. We have kept it very basic, simple. So there may not be that much of difficulty, but at least a learning point and how fast we are. So today the actual thing is, who is the Takana? Good, yaro pin number le join panirkinga. That is very nice. So, okay, so for people who have joined now late, so you can either, scan the QR code, or you can go into www.kahoot.it and then you can enter the gaming pin. Or if you have a Kahoot app, then the game pin is 9741036. So kindly all of you join early. So I just have 20, 21. So kindly join fast. We will give you another minute or so, and then with whomever we have, we will start the quiz. So actually, once I went to the Kahoot, I'm not able to see the Zoom platform. Deepa ma'am, are you there?
I'm there.
So,
I'm there,
so if somebody is facing a problem, you can, ping us in chat box so that we will know. And I can wait for you. Kindly, whoever has stayed, please stay back. Just don't leave the platform. Okay, kindly make it refreshed and stay there. Okay, so, and this Kahoot platform, it depends definitely on the, your connectivity. So try not to scribble on the actual there, and no answering on the chat box. We don't want your answers. Kindly answer in Kahoot alone. Okay, so don't put the message on the chat box. Deepa ma'am, can we start or we will have more people?
Yeah, we can start. Because you have 50 questions, it will take another half an hour. So please go ahead.
Okay, if you are still there. Yes, 32. Deepa ma'am, should I wait?
Start. 32 enough. At
Dr.
least
Janani, are you there? Dr. Janani?
Yes, ma'am. Yeah.
Yeah.
Am I audible?
Okay. I can't hear you actually, sorry.
Am I audible, ma'am?
Yeah. You are. Thank you.
Yes, ma'am.
So actually, I don't like the music of Ton 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 Ton. So I will mute it. If anyone loves that Ton 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 Ton, I can keep it. Because I've always felt it very annoying. I
Yes.
always try to mute that sound. If anyone loves to hear it, I can keep it for you. Okay, so 33. Deepa ma'am, in the number rough around, I will start.
enough, 32 enough.
For the ma'am? Okay, so I will start.
4.
Okay,
Start.
Jenny, over to you.
Good evening to everyone. This is a basic question quiz session on APH, just for refreshing your minds. Let us start. Concealed hemorrhage is most likely to cause which of the following? Minimal pain. Should I read the options also, ma'am?
Yeah.
Minimal pain, shock disproportionate to visible blood loss, a painless bleeding, or a warning hemorrhage. What is a concealed hemorrhage likely to cause? So the answer is B.
So most of them got it correct.
And Dr. B is leading. So in a third trimester, a patient presents with pain, uterine tenderness, and there is fetal distress. On the scan, we are not able to find an retroplacental clot. What do we do? Is abruption excluded? Is this placenta previa? Is this vasa previa? Or a clinical diagnosis of abruption still remains? Uterine tenderness, fetal distress, ultrasound doesn't show an RP clot. Yeah. The answer is the clinical diagnosis of abruption still remains. Abruption is always clinically diagnosed. The answer is, it's Ian who is leading the thing, and followed by Sukada ma'am and Dr. Ramalakshmi. Yeah. Coming to the third question. What do we do in a primey, 38 weeks, abruption with fetal death, mother is stable, cervix is 2 centimeter dilated? Should we do an emergency section, a vaginal delivery, wait for 48 hours, or forceps delivery? What do you prefer? 38 weeks, abruption with fetal death, but mother is stable and cervix is 2 centimeter dilated. Yes, preferred mode of delivery is vaginal delivery. As long as the mother is stable, we would prefer a vaginal delivery only. Leader is N again. Leader is Sukada ma'am, followed by N. That's Dr. Sandhya, followed by the number. So APH followed by decreased fetal movements. CTG shows sine wave oscillations. What does it represent? Maternal hypovolemia, fetal hypoxia due to abruption, fetal anemia from vasa previa or placenta previa. Sine wave oscillations, clinically presenting as APH followed by decreased fetal movements. Answer is fetal anemia from vasa previa. Dr. N is leading, followed by Dr. Sandhya, pin number, Dr. Unicorn, and Dr. Sharanya in the 5th position. Coming to the 5th question, 34-week primey as complete placenta previa gives an history of I think
The
it's not
USG shows
G1.
lacunae and loss of clear zones.
I think it's
So,
G1 தப்பா இருக்குன்னு நினைக்கிறேன். I'm sorry. Is it
sorry,
an abruption, placenta accreta spectrum, vasa previa or succensurate lobe? USG shows lacunae, loss of clear zone. What does it indicate? Yeah, the answer is placenta accreta spectrum.
Almost all of them have got it correct. They didn't show the mistake of primey there.
Okay. It's Dr. N followed by the numbered doctor, then Dr. Sandhya, Dr. Unicorn, and it's Dr. Sharanya then. Coming to the 6th question, a 36-weeker had rupture of membranes followed by sudden painless vaginal bleeding. Maternal vitals normal, CTG is as follows. Does it indicate an abruption, a rupture uterus, a vasa previa rupture, or a cord prolapse? Rupture of membrane following vaginal bleeding and the CTG showing a prolonged bradycardia. The answer is vasa previa rupture, which is really a nightmare.
Yeah, because painless is the crux there. Usually abruption doesn't come as painless, nor your rupture uterus.
And that following the rupture of membranes is another clue. That so it's Dr. Sandhya, Dr. Sharanya, Dr. Sugada, Dr. N, and the numbered doctor in the 5th position. Next question. Primey with abruption and ongoing bleeding. Hemoglobin is 10 grams, but blood pressure is 90/50. Respiratory rate is, pulse rate is 106 per beats per minute. What do we do? No transfusion since HB is normal. We wait till the HB to fall below 7 grams, or do we start blood resuscitation based on the clinical status? Give only IV iron. Yes, everyone got it right. Clinically, we judge and we start the blood. It's Dr. Sandhya followed by Dr. Sugata, Dr. N, Dr. Sharanya, and Dr. Maji has entered the team now. Covillar uterus is mainly due to placental villus invasion or blood extravasation into the myometrium, blood extravasation into the endometrium, or defective trophoblastic invasion. I think everyone will get this right. Yes. It's due to the extravasation into the myometrium. It's Dr. Sandhya followed by Dr. N and Dr. Sugata in the 3rd position. Which laboratory parameter best correlates with the severity of the abruption plus abruption? Is it hemoglobin, platelet count, coagulation, fibrinogen? Serum fibrinogen is the best marker. It's Dr. Sandhya, Dr. N, and Dr. Maji has come to the 3rd position, and it's Dr. Ramalakshmi and Dr. Divya have come in. So massive transfusion worsens coagulopathy due to all except dilution coagulopathy, hypercalcemia, hypothermia, acidosis. Something which we encounter rarely, but it's very important. The answer is hypercalcemia. Hypocalcemia happens. So
Yes.
massive transfusion worsens coagulopathy due to hypocalcemia. Dr. Sandhya is now leading, followed by Dr. N and Dr. Ramalakshmi, the 3rd position. Coming to the 11th question, abruption is least associated with which of the following? Cocaine use, trauma, smoking, hypothyroidism. Yeah, it's hypothyroidism.
I think some of you misunderstood for most, I think.
Dr. Sandhya followed by Dr. N, Dr. Ramalakshmi, Dr. Maji, and Dr. Divya are leading the scoreboard. 4 participants have answered this streak. Yeah. Severe abruption and IUFD develops, but there is persistent PPH in spite uterotonics. What is the reason? This is due to uterine inversion, placenta accreta, a cervical tear, or a disseminated intravascular coagulation. Persistent PPH despite uterotonics. Yes, the answer is disseminated intravascular coagulation. It's a dreadful complication of abruption. Dr. Sandhya leading, followed by Dr. N, Dr. Maji in the 3rd position. 4 participants have reached the answer streak 8. Sentinel event precipitating abruption in polyhydramnios. I think everyone would crack this. Sudden uterine decompression, hyperglycemia, rupture uterus, or a trauma. Yes, sudden uterine decompression. So it's Dr.
Scoreboard is pretty much the same.
So during massive transfusion, citrate toxicity from blood products causes. Hypercalcemia, hyperkalemia, hypocalcemia, or hyponatremia. Please don't enter the answer in the chat box. Please answer in the Kahoot app. The answer is C, hypocalcemia. Now it's Dr. Sandhya, Dr. Ramalakshmi, and Dr. Divya in the first 3 position. Dr. N and Dr. Sukata following them. Grade 3 placental abruption includes what among the following? Bleeding only, fetal distress, fetal death plus or minus coagulopathy, and 4th option is maternal shock. Some of them are answering in the chat box. I think
Yeah.
whether they have difficulty. The answer is option C, fetal death plus or minus coagulopathy.
See, I can see, I think you have not entered the Kahoot app and we have started, but at least, like you cannot answer so that let the other people also answer. It is very distracting if you answer in the chat box. So kindly avoid answering it in the chat box. So I think scoreboard is pretty much the same.
Characteristic CTG finding in acute placental abruption.
Of the 4 CTGs, you have to choose. So this is abruption we are asking. So for first one is looking like a sine wave. Second option, it's like what kind of deceleration you should see. Third, there's return. So second option is early. Third is variable. Late one, you can see a late decelerations with a loss of
variability. Yes, the answer is option D. So there will be late decelerations with loss of variability in abruption, which is characteristic of abruption.
Yeah.
So it's Dr. Sandhya, Dr. N, and Dr. Ramalakshmi, Dr. Maji, and Dr. Divya. We expect some more people to come into the team.
Yeah, score toppers.
In suspected placenta previa, which is contraindicated? Speculum, it's a very easy question. Speculum examination, transvaginal ultrasound, digital examination, or low segment work.
Wonderful.
Yeah. The most common risk factor associated with placental abruption is smoking, a previous abruption, maternal hypertension, or polyhydramnios, which is the commonest risk factor associated with abruption. Yes, the answer is maternal hypertension. Yeah, Dr. Maji is in the 2nd position, Dr. Sandhya is in the 1st, and Dr. Sukata is in the 3rd position. Dr. N and Dr. Ramalakshmi are in the 4th and 5th position. Dr. Bharati is the highest climber, it says. So, 32 weeks, major placenta previa, the bleeding has settled. She's hemodynamically stable. What do we do? Do we do an immediate section, induce labor? Do we assess the cervix by a digital examination, or we wait out, give corticosteroids? Major placenta previa, bleeding has settled. She's hemodynamically stable. 32 weeks, the best management. Yes. It is expectant management plus corticosteroids. As long as the bleeding has settled and hemodynamically patient is stable, it's better we wait. So it's Dr. Sandhya who's stopping. The preferred imaging modality for suspected placenta accreta spectrum is a CT, MRI only, on an ultrasound with color Doppler, or the intraoperative finding. The answer is an ultrasound with a color Doppler.
Whenever any choices says only, usually they are not very correct. And usually we diagnose by ultrasound with color flow, and not everybody, the diagnosis is not always by MRI.
MRI. So Dr. Sandhya being at the top. In severe placental abruption, consumptive coagulopathy occurs due to release of which of these chemicals? Thromboxane, a tissue thromboplastin, prostacyclin, or renin? Everyone got it right. Great. Tissue thromboplastin. So the scoreboard shows Dr. Sandhya topping again, followed by Dr. Maji and Dr. Sukada.
We have last few questions, so I think Yar and the Tucker matters. So just be fast. Whoever is the faster are going to be there in the top 5.
Do we know what the cryoprecipitate mainly contains? It's fibrinogen and factor 8, or coagulation factors 1, 2, 5, 7, and 8, factor 7 or factor 10. Yes, fibrinogen and factor 8, and it's preferred in DIC mainly.
So all other coagulation factors are seen in FFPs, not in cryos.
So it's Dr. Sandhya, Dr. Maji, Dr. Sukada, Dr. Ramalakshmi, and some, welcome Dr. Anjali has entered into the team now. We've got few more questions. Multiple placental lakes in third trimester without vascularity indicates it is always accreta. It is typically benign, normal variation in placenta structure, indicates placental abruption or a vasa previa. What does multiple placental lake in a third trimester without vascularity indicate? Yes, it's typically benign. It can be a normal variation in the placental structure. As long as there is no blood flow, we are not worried. So it's Dr. Sandhya again, Dr. Maji, Dr. Sukada, Dr. Ramalakshmi, and Dr. Anjali. 14 participants have reached the streak. The most dangerous APH for the fetus is a placenta previa, vasa previa, placental abruption, or placenta accreta. The answer is vasa previa. Yes.
So we are coming to the last question.
So
what is
Sandhya is
saying?
leading. Pregnancy diagnosed with vasa previa, no bleeding, reassuring fetus. Best planned delivery window will be at 32 weeks or 34 to 37 weeks, depending on risk factors. A vaginal delivery at 40 weeks or after spontaneous rupture of membranes. Yes, 34 to 37 weeks, depending on risk factors.
So we'll have the scoreboard. Third place is Dr. Sukata. Second place is Dr. Sandhya. Then the topper is Dr. Maji. So very nice. Congratulations. And we have Dr. Ramalakshmi and Anjali who are in the top 5. So congratulations, guys. Congratulations.
Congratulations to everyone, and congratulations to the winners.
So I've stopped screen. So thank you, Dr. Janani. That was such a wonderful quiz. So I would like to give it to you. You really made a lot of effort to put the questions this time. So it was very nice. Congratulations. It was well conducted and a well organized quiz. So and thank you, Dr. Charania. That was a very good presentation.
Thank
And
you, ma'am.
in
Thank
a
you for the
video
opportunity.
presentation as well. And congratulations to both Dr. Anandi and Dr. Sugata madam. Excellent debating. And thank you, Dr. Jayashree madam, for being with us throughout, for being the judge for the debate, as well as for the moderator for the journal club. So over to Dr. Deepa Tangamani madam.
Thank you, ma'am, for the opportunity.
Thanks, Janani.
Thank
As
you,
usual,
ma'am.
it's an excellent session. And I would say it's a very, very quality session. Thank you, everyone, one and all. And I wish everyone of our teams has to follow this. Thank you. Thank you so much.
And for winners of the quiz, if you can put who you are from the chat box, it will be so lovely to know all of you. So Dr. Marji, Dr. Sandhya. Hello, madam. Hello, Dana madam. Dana madam, you're mute.
Very nice.
Thank you, ma'am.
That
Thank you.
debate was too good.
I think Marji is Majabin Bashira. I thought so. So Dr. Mahajin, Majabin, sorry, Majabin. Which college? Yes.
Yes, ma'am.
Dr. Majabin, which college?
Good evening, ma'am. I'm
Good
an
evening,
associate
ma'am. I'm an
professor at
associate professor
Lalitandra
at
Medical College.
Lalitandra Medical College.
Oh, very nice. Congratulations. Others, Dr. Sandhya.
I'm from ACS Medical College, ma'am.
ACS Medical College, wonderful. And we know Dr. Sugata was there as one of the winners. Dr. Anjali. One more person. Postgraduate. Sorry, postgraduate.
From MMC, ma'am, Madras Medical College.
Okay, very nice. Congratulations. And one more winner, I'm sorry.
Dr. Ramalakshmi, ma'am. Dr. Ramalakshmi.
Ramalakshmi is from, I think, one of the PGs. So she's not there. So I think we have come. So Ramalakshmi, you are from which college, Ra? Muted, Kanna, you are muted.
I'm senior consultant from Aishwarya Hospitals, ma'am.
Okay, senior consultant. Okay. Now could PG next.
Hi, ma'am. Thank you,
Okay,
ma'am.
so thank you, one and all. And I think we come to the end of the session. So thank you everyone for joining with us. And we anyway have a YouTube link for people who think you have missed it. We will send the link. You can just go through that. Thank you. Thanks a lot for
Thank you
staying.
so much, ma'am. Thank you.
Thank you.